Good evening. Thank you for this great opportunity to speak to you tonight. Talk to the Tipton training group. It's an honor and it's a pleasure. And Paul, thank you for giving me this opportunity. So my topic tonight is implants versus endodontics, clinical controversy, decision-making and treatment possibilities for saving teeth. A conundrum and an issue that causes a great deal of concern to me, especially when I know that many teeth are lost and implants placed when those teeth could be saved. Now, if I can get my slides right. So, when we talk about implants versus endodontics, we have to consider the following facts. We need to define what success is in terms of implant success and endodontic success. We need to look at the problem areas. We need to consider whether the treatment is carried out by a specialist or a general dentist. We obviously need evidence-based publications to back up our treatment modalities. And I want to share with you the impact of modern technology in today's endodontics, so that you can see some of the wonderful things that can be achieved. So first of all, we should look at the question of success and the definition of success, because for endodontics and for implants, these are two different considerations. Excuse me. So when we define success for implants, we're talking about implant survival. And when we're talking about the definition of success for endodontics, it's the ability to cure existing disease. And endodontic success studies measure both the healing of existing disease and the occurrence of new disease. So success-wise, we have two different methodologies to determine the question of success. So traditionally, when we look at success in endodontics in terms of healing, we're dealing with a condition known as apical periodontitis, or in fact, we could call that periodontitis of endodontic origin, because a lesion of endodontic origin can occur anywhere around the surface of the root, as long as that lesion is within the bone. Without the bacteria, we do not have endodontic disease, and we cannot have apical periodontitis. From Kakahashi in 1965 through to Muller, Sundqvist, and the Swedish group, we well know that bacteria are the cause of our issues. And the aim of treatment, therefore, is to eliminate infection, remove the bacteria, and provide the best biological environment for healing. So I want you to look at this image, this X-ray, and you can see that it's been root treated. If I may say so myself, I don't think it's a bad root treatment. But I have to ask the question, and I ask you the question, is the treatment complete? And the answer to the question is no, the treatment is not complete. The canals have been shaped, the canals have been cleaned, the canals have been filled three-dimensionally, but the treatment is not complete because the final restoration or a core has not been placed on the tooth. And we'll look at this in much greater detail as we progress through this lecture, because if we fail to restore our teeth after root canal treatment, we can expect the case to fail. And the restoration of a root-treated tooth is more likely a greater determinant in terms of the success of the treatment than it is of the root treatment itself. So if we look at the prevalence and quality of endodontic treatment on a worldwide basis, and we look at inadequate treatment versus apical periodontitis, we can see that there is a very high incidence of inadequate disease. And when we have inadequate treatment, we have a high incidence of apical periodontitis. So if these treatments are not carried out successfully, if treatment is not adequate, If we don't basically do the job properly, we have a high incidence of apical periodontitis. And on that basis, we can expect failure in terms of healing. And with these types of results, and with these types of figures, it's very easy to say endodontics simply doesn't work. Let's take the tooth out and place an implant. So when we look at endodontic studies, when we look at implant studies, and we look at the question of success and failure, it becomes very obvious that the majority of endodontic studies in terms of success, the treatments have been carried out by GPs or students. Whereas when we look at studies on success for implants, we can see that the majority of the treatment is carried out by specialists. So that is a significant bias, even if we're trying to compare the two treatment modalities. And in fact, a bias, a publication bias, is more likely to exist when a particular brand of implant is studied, whilst endodontics is mostly generic and not necessarily related to the file or even the filling technique. Furthermore, only 13% of implant studies have an evaluator who is different from the operator, whilst 88% of the endodontic papers had independent evaluators. So we don't really have a level playing field. And then who's carrying out the treatment? Is it a general dentist or is it a specialist? And this interesting study going back as far as 2004 clearly shows that teeth treated by generalists have a success rate in terms of healing of 89.7, whereas teeth treated by endodontists had a success rate of 98.1% over a 5-year period. Endodontic treatment by specialists is therefore significantly more successful in terms of just healing. So when you look at some of these cases tonight and you see some of these outcomes that I've managed to achieve, you have to put your hand on your heart if you're a general dentist and say, can I do this? Is this something that is within my area of expertise? Because if it isn't, you need to consider sending that case to a specialist who would obviously do a better job. And why do endodontists do better job? Well, for a start, we find all the canals. We find all the canals because we have microscopes. And when we find all the canals, we find that second MB canals were located in 93% of first molars and 60% in second molars using the microscope. Is everybody out there finding 4 canals in an upper first molar? If I don't find 4 canals in an upper first molar, I can expect at some stage to have a failure. So this is how we're working at the moment, unfortunately, in these difficult COVID times. Everything is covered over. We're using our microscope, and we've got shields, horizontal shields, vertical shields to help us with aerosol production and keep us safe, staff safe, and obviously the patients safe who are going to be following up into this surgery. So if you look at this upper first molar, it's actually got 3 root canals in the mesial buccal. It's got a distal buccal, 3 mesial buccal canals. It's got a palatal in here as well. It's got 5 root canals. So if you only find 3 root canals when there are 5, well, you're 40% down from where you should be. And you hardly need to be a rocket scientist to understand that this case could easily fail because all the canals weren't found. The canals weren't found. The canals weren't shaped. The canals weren't cleaned. And subsequently, they weren't filled. And any of these areas where we've missed anatomy, we can expect bacteria to multiply and ultimately lead to a failure. So this tooth has got 1, 2, 3, 4, 5, 6, 7 portals of exit. These all need to be cleaned. These all need to be filled. And once they need to be shaped, they need to be cleaned, they need to be filled, and ultimately the final restoration needs to be placed on the tooth. So if we don't get it right first time, what about second time? Can endodontic retreatment be successful? And this is one of the classic studies from Bergenholtz from 1979, retreatment of endodontic fillings. And following a 2-year observation period of 556 cases, retreatments carried out because of technical inadequacies alone were successful in 94% of cases. So we need to get it right. And if we don't get it right first time, we do have a chance the second time. And if we can do it a second time and do everything as if it was the first time, we can expect a successful outcome. So here we have this case. It obviously needs retreatment. Why did this case fail? This case has failed because basically the endodontics was of an extremely poor standard. In fact, it was more than of a poor standard. It was absolutely awful. And we can expect the root canal system within this tooth to be teeming with bacteria. And these bacteria are leaking toxins out into the supporting tissues, setting up a lesion of endodontic origin. So I go back into the tooth, I redo everything. I do all of this in a single visit. Why would the patient want to come back? I remove the gutta percha. I find all the canals. I shape all the canals. I clean all the canals. I fill all the canals. And then that tooth gets restored. And as you can see, we have a successful outcome. Not only has this case been a success in terms of healing, but it's also been a success in terms of survival. There's another one. It's been root treated. Some would say it hasn't been root treated too badly. But then if we look at the apical area around this mesiobuccal root, we well know the reason for the failure. Now, I don't need a cone beam scan. We'll talk about cone beam scans a little bit later. But I don't need a cone beam scan to tell me that the main reason that this has failed because we have a complex root canal system in the mesiobuccal root. So I'm going to open back into that tooth. I'm going to remove all the gutta percha from the mesiobuccal. I'm going to go back in, remove the gutta percha from the distobuccal. I'm going to remove the post from the palatal. I'm going to remove the gutta percha from the palatal. And I'm going to start all over again. But just look at the complexity of the mesiobuccal root canal system here. And I've got a file inside this middle mesiobuccal canal. And you can see the exudate that's coming from it. So whoever did this root treatment here has left anatomy, bacteria inside the root canal system. It's hardly surprising there's a failure. So I start all over again. I shape, clean and fill the mesiobuccal canal, distobuccal canal, palatal canal, and then I get that tooth restored. That lesion heals very quickly in an extremely short space of time. I have success in terms of healing, and I have success in terms of survival. So as the more recent years have gone by, it's fair to say that we can use the term survival in endodontics. And in order to establish comparable outcome criteria between endodontic and implant procedures, it is critical that the same measure is used to make this assessment. And this will give us a much less biased comparison between the two treatments. So, this lower left second molar, it's got a large lesion of endodontic origin. It's symptomatic. The cause of the problem is because the pulp has become necrotic. The root canal system is full of bacteria. I open into the tooth. I shape it. I clean it. The canals are dry. I have the time to fill it. So I fill it. And then I get the tooth restored. And within 6 months, we have complete healing and we have survival. Here we have a case of indeterminate healing, but without doubt we have survival because this tooth is re-root treated. And in trying to remove the root filling material from the mesiobuccal root, I unfortunately got a perforation. We'll talk about that later. And in getting a perforation, I have to repair that perforation. I didn't entirely get down the mesial canals. This is my final outcome, but I get the tooth restored. And over a 10-year period, we still have a small lesion of endodontic origin. The tooth is asymptomatic, and this tooth has survived on a 10-year basis. So going back to the restorative impact, Lazarski looked at over 110,000 endodontic cases over 4 years, and he found that teeth that were not restored were significantly more likely, by up to 4 times, to undergo extraction. And so the restoration of an endodontically treated tooth is a major determinant of its survival. So I root treated this tooth, and as I usually do, I seal the canals with some glass ionomer and then put a pledget of cotton wool and a temporary filling. Send the patient back to the restorative dentist and ask the restorative dentist to remove the entire temporary contents to the floor of the pulp chamber and the gutta percha, and then to restore the tooth with a bonded core and a crown. So this is a pretty difficult root treatment. It was actually completed with Wave 1 Gold. So I'm rather proud of this case because I'm one of the developers of Wave 1 Gold, and I managed to achieve a pretty decent result. However, when the patient comes back to see me 1 year later for a recall, this is what I see. Not only have the pulp chamber contents not been eliminated, not only is there not a core, but the crown on the tooth is leaking. I can actually expect this case to ultimately fail. Whose fault is it if it fails? Is it mine, or is it the restorative dentist's? Invariably, the endodontist will get the blame. Ultimately, I ask the restorative dentist to remove the crown, place a decent core, and replace the crown. We wait to see what happens with this case. So the American Academy of Osseointegration, 2006, they entrusted Iqbal and Kim from the University of Pennsylvania to systematically review clinical cases of the survival of single-tooth implants and endodontically treated and restored teeth to compare results. So when we say survival of single-tooth implants, these were implants supported crowns. So both teeth had to be restored. So this was an in-depth meta-analysis. And the outcomes compared survival of the restored root canal treated tooth to the restored implant. A meta-analysis of 57 studies totaling 12,000 implants and 13 studies totaling 23,000 root canal treated teeth. And the outcomes were interesting over an 8-year period. Because in that period of time, when it came to the question of survival, implant-supported crowns and root-treated teeth with their crowns survived at the same level. But what was more interesting, perhaps, was that 18% of the implant cases needed follow-up intervention. That being the case, I would say to you that any tooth that needs a follow-up intervention cannot really be considered as a successful outcome. So in this interesting study, 196 patients received RCT with coronal restorations, and they were matched to 196 patients receiving implants. It was a 10-year follow-up. Both groups had an overall 94% survival. However, patients with dental implants were 5 times more likely to need unplanned treatments to maintain survival. We know what those unplanned treatments are. They're for prosthetic repairs. They're for replacement loose crowns. They're for lost implants. Once you carry out the root treatment, get the tooth restored, well, there's nothing left to do, is there? I hardly call it a successful outcome in terms even of survival if the patient is backwards and forwards every 6 months or a year with a problem related to the prosthesis on the implant. In fact, in the United States, they have what they call the facial shield program. So the implant, the dentist who places the implant can take out an insurance policy against problems related to the restoration of the implant once the implant has been placed. Who's ever heard of anything so ludicrous? In endodontics, where does this happen? Shape the canals, clean the canals, fill the canals three-dimensionally, restore the tooth, and that's it. It's all over. And then we see these issues with our implants. There's a huge issue in the implant world with perimucositis and peri-implantitis. So evidence concerning the influence of both is now well established, questioning the benefit of tooth extraction and implant placement. Would you call this a good quality of life? We've got a perimucositis around the crown margins of this tooth. And here we have a peri-implantitis and a considerable amount of bone loss. Is this what the patient signed up for? So not all perimucositis cases lead to peri-implantitis, but all peri-implantitis cases start with perimucositis. And after 11 years, peri-implantitis is found in 1 out of 4 patients who had implants. And after 11 years, peri-implantitis is found in 1 in 6 patients who had. This actually should be perimucositis. This is peri-implantitis. This doesn't look very well for an implant. So has the patient been informed at these issues, and do they know that there's a possibility that they could have chronic periodontal disease associated with an implant? Look at the bone loss around these implants. With implant placement, 1 millimeter of bone loss is lost. 1 millimeter of bone is lost during the first year of placement, with an additional 0.1 millimeter annually. Although it can vary with implant type and material, but this tooth is in the mouth. It has survived. But let's be honest, this case is certainly not a success. So the loss rates of implants is higher than that of natural teeth in clinically well-maintained patients. The implants are more susceptible to plaque-related disease than natural teeth. The long-term survival and success rates are much lower in patients with prior periodontal disease, even with maintenance, bearing in mind that a huge number of implants are placed by periodontists anyway, as they couldn't maintain the tooth from a periodontal standpoint, so the tooth was lost and an implant was placed. But what is more important is that retaining molar teeth with furcation involvement using various therapeutic approaches is more cost effective than tooth removal and replacement with implant-supported crowns. So if you were a patient, what would you really want? An implant that could lead to chronic periodontal disease, peri-implantitis, or a tooth that could be well root treated and maintained from a periodontal standpoint rather than tooth loss. But then, as far as endodontic treatment is concerned, it does have to be said that the success criteria in terms of healing is a reflection on the technique. And there are various techniques used, but at the University of Toronto, a study conducted by Shimon Freeman and his group over many years, they clearly showed that the Schilder technique, the so-called tapered preparation with the apical diameter as small as is practical and then warm vertical condensation, was a better technique in terms of healing outcomes. Bearing in mind that apical periodontitis and treatment technique are both the main predictor of outcomes in initial treatment. Now, I'm not going to use this lecture time to show you how to shape a canal or clean a canal. I'm sure that's been done elsewhere in this endodontic week, and I don't really care which instruments you use, basically. As long as you do it properly, as long as you shape the canal, as long as you clean the canal, and as long as you fill it three-dimensionally, you can expect a predictable outcome. It may take longer if you have an apical periodontitis. So when it comes to quality of life and comparing implants with endodontics, it has to be said, overall, patients were very pleased with the treatment received and expressed a clear message to save their natural dentition wherever possible. So please give your patient the option. If there's an endodontic issue with that tooth and you don't feel that you can overcome the endodontic problems, get a referral to an endodontic specialist and let the endodontist have a look and see what he thinks. Because if that tooth can be restored, and if it's periodontally sound within region, there's absolutely no reason to extract it. If your patient breaks their leg, ends up going to A&E, they don't expect to come home with a wooden leg. We're dentists. We've got hands. We know what to do. We know how to treat these cases. Use our hands to save teeth. That's what we went to dental school for. But then not every tooth can be saved. Can these teeth be restored? And what is the periodontal status? There's a huge amount of caries here, and there's severe periodontal involvement. There's caries underneath the crown margin here, probably as far as the furcation. I would say to you that both of these teeth need to be removed. Now, I don't need to be a hero, and I'm not going to save teeth that simply can't be saved. And we'll look at the decision-making process in a little bit more detail. But sometimes you take a step back. As an endodontist, I might get sent these two cases. Can I do anything? Well, I don't think I can, and I think the implants are going to be much more predictable for this patient and much better than anything I could possibly do. Andrew Darwood and Shannon Patel, probably well known to many of you. Shannon Patel is very well known in the world of CBCT. They put together this dental practicality index assessing the restorability of tooth. So they looked at the question of structural integrity, the periodontal and the endodontic treatment modalities, as well as the context. And then they work out a practicality index. So an overall score of greater than 6 may indicate that the treatment is impractical, and this is reduced to 4 if the tooth to be treated is to be used as a bridge abutment. So minimal residual sound tooth structure, probing, pocketing greater than 5.5 millimeters. We may have a simple root canal system, but we have isolation issues, and we have contextual complexity issues in terms of context. And so if we add up the practicality score here, we've got 1, we've got 2, 4, 5, we got a 5. So we may just decide that we can treat this tooth, but if it needs to be a bridge abutment, it's best to remove it. So, can the tooth be restored? Well, we've already got a periodontal defect. We haven't got very much tooth left. By the time we remove all of the decay here, I think we could be well into the furcation. I think there's a lot to be said for removing this tooth. If we don't remove the tooth and try and save it, the patient needs to realize they could have continuing problems. Here we have an extremely difficult root canal. We have caries, hardly any tooth structure remaining distally. We have periodontal involvement. Perhaps this tooth should be extracted. Caries. Coronal radiolucency. The odds are that this tooth is fractured. Well, the odds are that the tooth is fractured. It is, of course, fractured. Whenever we see a coronal radiolucency like this, 99 times out of 100, the tooth is fractured. That tooth should be removed. Are we going to try and re-root treat this tooth? We've got to get the crown off. We've got to remove all these caries. We'll probably go into the furcation. There's periodontal involvement. We've got to try and get that silver point out, which is ledged, and then get back down the canal. So you look at the practicality of doing this case, and I think you'd be better off with this because the implant would be more predictable. And then did you tell your patient this could happen when you placed an implant? Did you tell them when you placed this implant that they could shave the end of the adjacent tooth off? So this patient comes to me for a root treatment and asks me, why has the problem occurred? What am I going to tell them? Be far better if you told them before they started that there was a risk this could happen, and this was the chance they take when they have the implant placed. It's okay by me, because that means that's another root canal for Julian Weber. And another one, shaved off the end of this canine in placing the implant. It's another job for the endodontist. Whoopee, hey ho. Tell your patients all the risks before you carry out any treatment, especially your implant treatment. And then there's the question of costs. And although we can go back to this Gordon Christensen study from 2006, I think these figures are probably just about right for implants versus endodontics in the West End, maybe a little bit more now. But in 2005, a restored implant could cost you anything up to 3,000. In the West End of London, I think you're talking at 4,000. Whereas a restored root-treated tooth, about 2,000, 2,500. So it's a much cheaper option to have your tooth root treated or re-root treated and then restored than it is to have the implant. And if you put it like this to the patient, surely they would always opt for the root treatment. But let's face it, implants are sexy. Root treatments, 2, 3, 4 hours, not particularly sexy. They get more for it than we do. Doesn't seem right to me. So this patient came to see me for a second opinion. Apparently the dentist had told him that the tooth needed to be removed because there wasn't enough tooth structure to restore it. Come on, give me a break here. We all know this tooth can be restored. We can root treat it, and then you can restore it. So has the patient been informed of the treatment alternatives, the risks, advantages, disadvantages of all, and disadvantages of the alternatives? Why would any dentist want to take that tooth out? But believe you me, there are plenty out there who would. The tooth patient didn't come back for the restoration, but I assume they still have this tooth. So when it comes to endodontics, we can do some amazing things. And endodontics today is very technologically driven. We have a CBCT, cone beam computed tomography. We have magnification and microscopes. You're not an endodontist. Let me repeat that. You're not an endodontist. You're not an endodontist unless you have a microscope. And you're not an endodontist if you don't have access to CBCT. And I'll show you why in a minute. We have ultrasonics to help us find canals. We have automated preparation with nickel titanium. We can obturate and three-dimensionally fill the root canal system. We can carry out complex retreatments and perforation repair. We've got new wonderful bioceramic materials, MTA, biodentine, and we can also carry out apical surgery very successfully. But whilst we have all of these wonderful technologies, it is interesting to note that for some very strange reason, and although this study was in 2009, a survey carried out amongst general dentists across Europe by this team from Lithuania, they noticed the striking finding of a generally negative attitude amongst general dentists towards performing endodontic treatment and adopting new technologies in daily practice. So that means if you want to do good endo, you've got to go out there, you've got to spend your money. You need to spend your money on all this equipment. And you need to go out and have continuous dental education in order to update your knowledge on endodontic technique and treatment possibilities. If you can't do it, however, remember, there's always somebody who can. So let's look at cone beam in endodontics. Well, the two main players in cone CBCT for endodontics is the Marita Verifew X800 and the Carestream CS9000 3D CBCT machine. My preference is for the Marita Verifew. it helps me in so many respects. And I ask for a small volume, so I'm not interested in a whole arch. I'm not interested in the whole mouth. I'm interested in a small volume, say 3 or 4 teeth within that volume. And then I can get a clearer estimation of what is going on. So sometimes I need to see whether there's an apical periodontitis because I simply can't see that on the radiograph. So this patient is symptomatic with pulpal symptoms. You'd certainly expect the problem to be this first molar tooth, but the patient is absolutely convinced it's coming from the second molar. Not only is the patient convinced it's coming from the second molar, interestingly, none of my tests, those of you who are going to join me on Monday, none of my tests seem to give any sort of adequate response. So I'll send the patient off for a CBCT. And you can see straight away on the CBCT that that molar tooth has got an apical periodontitis. That's my culprit. That tooth is root treated through the crown, pulp chamber is restored. So this tooth was having pulpal symptoms. The dentist root treated the second premolar tooth. We're not necessarily going to criticize that root treatment. That's not what I'm here for tonight. However, the patient is convinced that the continuing pulpal symptoms are coming from this second premolar. You know as well as I do that I'm going to tell you that it's actually the first premolar, but there doesn't seem to be any huge changes here. The teeth in this area are tended to percussion, tended to chew, but if I take a cone beam, you can actually see that both teeth have got an apical periodontitis. So in the case of the first premolar, we've got an acute pulpitis with early apical periodontitis, and we got a root treated tooth that's got an apical periodontitis. This is great news because it means I can root treat the first premolar and I get to re-root treat the second premolar. So a well root treated tooth, not a bad root filling. I'm sure you've seen worse. It's got a crown on. Patient is complaining of continued sensitivity. Tended to chew, tended to bite. No periodontal probing. There's no pocketing. What's going on? Well, that's what's going on. You've got a large apical area around the distal, and you've got a mid-root lesion around the mesial. A mid-root lesion like this, in the presence of a reasonable root filling, is nearly always 100% definition of a fracture. That tooth has to be extracted. So how about a trauma case like this? Our standard radiographs show us the extent of resorption after these teeth were variously avulsed and replaced. Root treatment was carried out. Not a very good root treatment, of course, as you can see here. But there's extensive resorption. What are you going to do? Just go straight back into these teeth and start all over again? Or are you going to take a cone beam scan? Because if you take a cone beam scan, you can see the extent of the issues. Hopeless amount of resorption. Hopeless amount of resorption. Here we've got a sagittal view here of this central incisor. Unfortunately, this tooth is shot to pieces. Here it is here. Here it is here. Internal resorption, external resorption. Hardly any tooth left apically. This is a sad case that will demand virtually extraction of nearly all of these teeth. But if you didn't have the cone beam, you could very well consider you might go in and start some treatment. What about root canal anatomy and morphology? So this is an interesting premolar, but you take a look at this tooth, you take a periapical, you see it got a very large canal that suddenly disappears. What is the cause of that? Well, the cause of that is the fact that that canal splits into two. That's what the cone beam tells me. The sagittal view of that tooth clearly demonstrates that. So when I make the access into this tooth, I'm going to be looking for two canals here, one mesial and one distal. you like to do this root canal? Would you like to go down here, have a look all the way down here? If you haven't got a microscope, see the canal split into twos? There it is here. Sorry, mesoid, buccal and lingual. And there you can see we've root treated that tooth to a high standard. So what's going on? Well, we probably know that there's an extra canal, maybe even two in this mesiobuccal. We can't see much in the way of apical periodontitis. We're short on the palatal. The cone beam gives a different story. For a start, the mesiobuccal, we can see here the coronal view of this mesiobuccal. The root canal is not in the center of the root, meaning there must be another canal, which there is here, and there's a lesion of endodontic origin. We're short on all of the canals. You can see here confirmed a fourth canal inside this tooth. So this information is very helpful when I go back in to retreat. So this looks like a simple case of endodontic retreatment. We know there's a likelihood of a second canal here in the mesiobuccal, but we're short on the palatal and we're short on the distal buccal. Is there anything else to see on this? Not much. But look what we find out when we get into the cone beam. For a start, there's a big internal resorptive defect. In hindsight, you can just about see it now. We can also see that we've got a missed mesiobuccal canal. And so we can retreat this tooth, use a technique which will seal the resorptive, internal, non-perforating resorptive defect and get the tooth restored. Valuable information from the cone beam. What about resorptions in general? So are you going to tackle this case on the basis of this intraoral radiograph? Or are you going to call for a cone beam? And look what the cone beam has shown you. This tooth is decimated. Half of it is destroyed coronally. And this defect extends well below the level of the bone. And even were you to try and seal this area, this patient would have a constant periodontal defect. Maybe you'd be better off extracting that tooth. Simple case of resorption. Large area. Are we going to treat it? Or are we going to get some more information? Well, that's the information from the sagittal view of that tooth. But look what happens when we get an axial view. We can see that the whole side of the tooth is destroyed. So on the basis of the imaging, we've made the diagnosis that unfortunately we can't help this patient. So the dentist thought this was caries, asked me to have a look. This was an image taken by the general dentist. I sent the patient for a cone beam. Look at the extent of the destruction. There is no way we can save this tooth. Here's another one. This first molar was root treated, and the question was, could we root treat this second molar with a large apical area? First of all, the sagittal view of this tooth does indicate to us we've got a considerable area of bone loss. There's this area of resorption. But let's look more closely at this radiograph. Let's look at this region here. Here, right here. What's going on here? But there's another defect there. And if we manipulate the image, here's the axial view, we can actually see the extent of that defect. The tooth is likely not treatable. I hold up my hands and I say, I'm sorry, can't do anything here. So you would think on a standard radiograph this looks pretty innocuous. Periodontal problem. There's an extensive amount of bone loss, both apical and periodontal. But look at this. Look at the extent of the resorption here around the distal root. Yes, we could consider a root amputation, root treat the mesiobuccal and the palatal, but we haven't got much here in the way of restorative options, and all these factors have to be put to the patient. Perhaps overall an extraction is indicated. Here is the extent of that bone loss and resorption around the distal buccal. I'm sure you'll agree that at least this route is hopeless. And what's going on here? Is this a defect in the bone? This patient is having pulpal symptoms. It's come for a root treatment. I take this radiograph and I see this problem. I know that I need to get a cone beam. And that's the extent of the resorption on the palatal root. The tooth is shot to pieces. The coronal view clearly shows me the extent. By the time I remove any of this, I'm going to be into the furcation. Apical area, apical area. The CBCT has helped me with the diagnosis. So diagnosis of fractures. Not always easy. A relatively decent root treatment. The flag on this one is this coronal radiolucency. There's this coronal area of PDL thickening. Tooth is tended to percussion, tended to chew. Not a bad root treatment. I send it for a cone beam, and hey ho, look at that. A fracture on the axial view, one side to the other. I'm afraid it's the dustbin for this one. So what have we got going on here? Well, we know we've got an apical area here on the mesiobuccal. We know there's probably a likelihood of a second mesiobuccal canal. But look at the cone beam here. So this is the sagittal on our cone beam. We've got this lesion of endodontic origin. We've also got a lesion on the coronal aspect of the mesiobuccal root. And if we look more closely on the axial view, it looks like we've got a fracture. I can manipulate these images, I can expand these images, and they can give me a clear indication of what's going on. There's a lot going on here, but there isn't enough information from the standard radiograph. This is the cone beam. We can see all sorts of problems on the first molar, but look at the second molar. For a start, we got a fracture here of the distal buccal root. The whole tooth is enveloped by bone loss. The prognosis is extremely poor. You can't do what you can't do. An extraction is indicated. At least this tooth can be re-root treated, but this one is hopeless. Perforations, iatrogenic issues. What's going on here? Is there a canal there? Where is that gutta-percha? That gutta-percha's in the bone. This guy's perforated. We possibly could consider a perforation repair. The patient opted for an extraction ultimately. And here's another one. The dentist called me, said, I found one of the mesiobuccal canals, but I can't find the main mesiobuccal canal. In fact, if you look at this x-ray, it does look as if there's the outline of a root here. I'm not so sure here, but I am suspicious of a perforation. And that is certainly confirmed on the cone beam. Is the patient going to have a perforation repair and a re-root treatment? I put this option to the patient. I told them I couldn't guarantee the outcome, and the patient also opted for an extraction. But at least they got an endodontic opinion. So we have cone beam and we have magnification. Seeing is believing. And we work very closely with our assistants who have access to the working area with an assistant scope. These are the good old days. But we can make perfect access cavities. We can diagnose fractures. We can locate all canals. Calcified canals we can find, complex anatomy, and retreatment. So what is it about a microscope? Well, if we look at this dollar bill and we look more specifically at George Washington's face, we need to understand the concept of resolution, which is the ability of an optical system to make clear and distinguishable two separate entities. So the resolving power of the eye is 0.2 millimeters. 2 points closer than 0.2 millimeters will be seen as 1 point. So the lines on George Washington's face are 0.2 millimeters apart. We can just about see them. But the square boxes around him are 0.1 millimeter apart and cannot be seen. And 100 bacteria could span that square. Remember, an open crown margin is less than 0.2 millimeters and it's not discernible. And on that basis, we need to know that a root canal diameter could be 0.1 millimeter or less. So if you don't have the magnification of a microscope, you're not going to find the canal. Now we can see more clearly. We'll bump up the magnification. We can clearly see the boxes. This is a millimeter between the boxes on the side of George Washington's face, blown up to 18 times magnification. You won't miss too many canals with this sort of magnification. So this is me with my global series microscope. It's light, it's easy to use. This is the all singing and dancing Zeiss Pro Ergo. This is about 50 grand with all the accessories. The Zeiss Pro, the Global is a lot cheaper. My feeling about it is I can get from A to B in a Mini. I don't need a Rolls Royce to get me from A to B. I don't miss anything really with my Global. In fact, all I have to do is peel back the soft tissue around the margin of the crown to see that there's a fracture. I probably wouldn't pick this up on a cone beam, but I clearly see it under the high magnification of the microscope. So we made access into this tooth, but then it becomes obvious to me I've got a fracture across the floor of the pulp chamber from one side to the other. This level of magnification may help me find all the canals, but unfortunately in this case it finds me a fracture. Unfortunately hopeless. So finding canals, use our ultrasonics. The major player when it comes to ultrasonic is the Action P5 machine from Satellec. I particularly like the Start X tips from Dentsply Sirona, and these 5 tips have different functions. The Satellec P5 is used in conjunction with the Stropco irrigator. The Stropco irrigator is a reduced air and pressure adapter that is placed onto your Forest syringe. The assistant can gently puff air and blow air into the access cavity or down the canal to clear the working area. Let's have a look at this access cavity. So I'm using the ultrasonics here. So I'm using the StarTex #2 tip to eliminate the pulp stone that is covering the floor of the pulp chamber. And the dentist is in there with the Stropco. She's cleaning everything away for me. Now I'm looking down on the floor of the pulp chamber. I water on, water off. I have very clear view. I don't have the head of a handpiece in the way, blocking my view. This is the StarTex #5, just to remove these little calcifications that exist on the floor of the pulp chamber. Delicately removing these calcifications. The assistant's in there with the Stropco, a mini tip on the end of the Stropco. She's blowing away all the debris. Water on, water off. Give this a good clean. Very well placed water ports on this. And now we can look down on the floor of the pulp chamber and we can clearly see everything. So we've got the distal buccal, 2 mesial buccals. Distal buccal. It's a DG16 Explorer. Mesial buccal. second mesial buccal, and of course the palatal. So sometimes we have to chase canals, and so we'll use the number 3 tip. We also use the number 3 tip for removing fibre posts. So we're looking in this region here. Look for the white areas. So we're going to remove all the gutta percha ultimately, but somewhere in this line between the main mesial buccal and the palatal, we find a little catch, and that's the MB2. And I'm going in there with my StarTex number 3 tip. So look what happens when the roof of the canal is exposed. Here it comes. Watch. There it goes. Whoosh. So that's what was left inside the root canal system. You hardly need to be a rocket scientist, as I said earlier, to work out why that case failed. We find all the canals, we remove the gutta percha, which I'll show you how to do later, and we start all over again. So this is a Dentsply Sirona stroke Mylefa orifice opener. It's a file on the end of a handle. So we can easily see what we're doing without our fingers getting in the way. We can relocate the orifice of the canal, so we have a much straighter shot at it. And there's our canal. And once we're in, we're ready to go. The rest is easy. So the general dentist has made a great effort to find this canal, but has decided to stop. How do I find the canal? Well, I draw a line on the surface of the tooth, which takes me into its long axis. I look inside the tooth and I can see this white line. So this is the calcification. So this is the color of normal dentine. It's a gray color. But secondary dentine, reparative dentine, or canal that has been closed up with dentine, a white line. Follow the white line. Chase the white line down the tooth, going in the direction of the long axis. Ultrasonics, find the canal. Once you find the canal, the rest is easy. Shape the canal, clean the canal, fill the canal. Hey presto, you're in with a chance. Now, some of you might have come across this system for implants. So this is the dynamic navigation system from Navident, targeting perfection for the best placement of an implant. So it's guided dynamic navigation. So when you place an implant, you scan, you plan, you trace, and then you place. But we can use this now for endodontics. So here we have this interesting case here, courtesy of Yossi Namias in Toronto, Canada, looking for a canal that's about 14 millimeters down, drilling through a crown, and he can use this like a sat-nav in his car to guide himself down as he goes along. So we're going to track the patient's maxilla with a head tracker. There's a registration tool. 3 teeth either side are registered, and we calibrate the handpiece and burr so that the plan that we have encompasses the entire area. And here we can see it here in action. So we need a cone beam of the tooth, and the program guides us down in real time. We can see that we're going in the right direction. I'm looking for a case to do like this. I haven't managed it yet, but it's some very exciting technology. If you're slightly off course, you can find your way back. Find the canal, you're ready to go. Dynamic endodontic navigation. This is the final result. Very pleasing. So when it comes to shaping canals, we can do that simply and we can do that quickly. And not only simple and quick, but we can do it safely, because shaping canals with single file reciprocation is probably the safest way to shape our canals with NiTi. We've got Dentsply Sirona's Wave 1 Gold, and we've got Reciproc Blue, which is from VDW, also a Dentsply Sirona company. I'm very proud to be part of the Wave 1 Gold design team, along with Cliff Ruddle, Sergio Cutler, and Willie Perteau. So reciprocation are unequal forward and backwards angles where the backwards is greater than the forwards to produce a cycle of 120 degrees. The instrument engages, and as it engages, it comes back the other way. These three cycles of reciprocation make a full 360-degree circle. So you do need either an X-Smart Plus or an X-Smart IQ motor, which is a very nice little system, which is Bluetooth to the handpiece via the app on the iPad. And then we've got various reciprocating motors that provide this backwards and forwards movements. If you want Reciproc Blue and if you want Wave 1 Gold, you need to buy one of these motors. So what is the big thing about reciprocation? The big thing about reciprocation is that it avoids breakage, because we see breakage a lot with continuous rotation, and we see breakage due to cyclic fatigue. This is one of mine. This is one of mine. This is one of, actually, this is not one of mine, but this is, and this is. Why did these instruments break? They break because of fatigue. Cyclic fatigue basically means that they continually rotate, and after a certain number of rotations, the metallurgy of the nickel titanium breaks down, the molecular structure breaks down, and there's suddenly bang, break. Torsional failure occurs when the canal is too tight, and we simply can't, the instrument binds, and as it binds, it wants to rotate, but it can't. The flutes unwind, and as I say, it breaks. So reciprocation has been around since about 2011. The mechanical properties of reciprocating files are better than rotary files. Reciprocating files are more resistant to fracture. Reciprocations and rotary clean canals of bacteria equally. Shaping ability of reciprocating files is as good or better than rotary. Reciproc Blue and Wave 1 Gold clean canals properly. And there was a question in the early days about dentine cracks, but that's a myth based on poor research methodology. So very quickly, the Wave 1 Gold technique, which is simple and easy, we get ourselves a glide path. We get a super loose number 10. When we've got a super loose number 10, we expand the glide path with the Wave 1 Gold glider, part of the Wave 1 Gold system. And then we shape the canal with the Wave 1 Gold primary. In 8 cases out of 10, that's it, we're done. There's matching gutta percha points, there's matching paper points, there's matching thermofill. All designed to match the shape of the file. And for those of you who like the gutta core system, which is gutta percha on gutta percha, similar to the concept of thermofill, but all gutta percha, we now have Wave 1 Gold gutta core. So this is so quick, it's embarrassing. You don't have to push on the file. The movement moves it to length. If there's any resistance, we come out and we brush. We shape the canal very quickly, and after we've shaped the canal, we can think about copious irrigation, enhancing the irrigation, use an endo activator, spend time on the irrigation. So here's a couple of cases: Wave 1 Gold and warm vertical compaction, conservative preparations. Some more cases here. That's a pretty curved premolar done with a number 10, a glider, and a wave 1 gold primary. You could all do that. So we have this long double curvature molar, 26 millimeters, long curved. Wave 1 gold will do this case easily. So yes, it's safe. The literature suggests that it's safe. This was an in-house study carried out in practice. Based on the results of this study, the incidence of instrument separation over an 18-month period by 4 experienced endodontists was considerably low. And then if you gave undergraduates rotary or nickel titanium, they'd probably opt for mechanical versus hand, but most of them opted for reciprocating single file systems instead of continuous rotating systems because they basically feel safer. We can fill the root canal system 3-dimensionally. That's what Schilder said. Eliminate all of the space within the root canal system. There are many cordless obturation devices for warm vertical compaction, from Dentsply Sirona's Gutter Smart to the Elements cordless from Kerr and the B&L Super Endo, as well as many, many more in the market. We're going to place a mashing gutter perta point into the canal coated with sealer. Kerr's pulp canal sealer or AH+, perfectly good sealers. Burn off the excess at the canal orifice. Drive the heated plugger through the gutta percha. You're then left with an apical plug of gutta percha. You can either place a post over it or you can backfill with the obturation device. Plug the apical mass and inject the gutta percha. How simple is that? But it's technique sensitive and you've got to spend time and money on the materials. And it's very easy just to go from one canal to the other. 3D obturation. There's that outcome, as you can see here. So let's talk about managing endodontic failure. We have to remove posts. So we've got the number 4 tip from Dentsply Sirona to remove metal posts. So we're going to use a combination of tips for this case. So this is the Startex number 2. We're going to remove excess core material around this serrated post. Could be a dentatus screw post. Can't believe today that people still use dentatus screw posts, but they do. So once I've removed the bulk of this material, I'm going to use a Startex number 3 for more delicate work. So release as much of the composite and core material around the post as you can, and then go at it with the Startex number 5. The assistant is in there blowing debris away. Here we go, water on, water off. And this thing just unwinds out of the canal. Starts to rotate, unwinds, out it comes. And we're going to use the same technique here on this large silver point or thin post. Was never sure what it was. Here's our final outcome. Sometimes in removing a post, we can't get it out ultrasonically, so we need one of these dedicated post removal systems. We have the Thomas from France and the clone of the same device from Cliff Ruddle. So we're going to dome and trephine the post, place our tubular tap after a post is bored, use the rubber extracting pliers and just crank the post out of the canal like taking a cork out of a bottle. We remove this post, we retreat the root canal, we get a new post placed immediately, and we get healing in very quick time. This is the Ultradent Unicore system. I'm not going to go into any great detail with it. Cliff very kindly gave me some video. Let's just see if we can. We're going to use these Ultradent Unicores going from small to large after having stained the fiber post, the face of the root, help us to distinguish between the core and the tooth structure. So we use an ultrasonic first. The ultrasonic is used first to make a pilot hole, and then we progressively go up through the 2, 3, and 4 to remove the core material. This way, we can safely remove a fiber post. Once we've got the post out, we may have to get gutta-percha out or carrier-based devices. Micromega have their Endo system, all designed to auger gutta-percha out the canal. FKG have their XB Endo finisher R for retreatment, and they also have their D-Race disobturation system. So many of these companies are making devices to remove gutta-percha. ProTaper Universal System has its own dedicated retreatment files. So we're going in about 800 RPMs. Notice when we're removing the gutta-percha, I have the tip of the electronic apex locator on the head of the handpiece. Here it is. So it gives me a visual readout on the apex locator machine if I'm getting too deep inside and going through the foramen. I go from D1 to D2 to D3. If there's a lot of excess material, I use this Mylefer debrider to pull out the debris. It's a headstrong file with a right angle headstrong file with a handle, so I can clearly see what I'm doing. And that's how we remove gutta-percha. When it comes to the thermofill, I have a similar technique. So when I look inside the pulp chamber, I can see where there's a mass of gutta-percha. Here's a mass of gutta-percha. Here's my carrier. And I'm going to drive my D-files into this area. Invariably, they grab the plastic carrier. I can remove the excess gutta-percha with the Mylefer debrider. Shape, clean, fill, restore, healing. Healing in terms of elimination of infection, healing in terms of survival. What about removing broken instruments? Well, there are a lot of endodontists out there who are absolutely obsessed with removing broken instruments. I'm not really one of them, but I do like a strategy. And my strategy is this, based on this article from '86. If the instrument's in the coronal third, I'll attempt retrieval. If it's in the middle third, I'll retrieve it or even bypass it. And if it's in the apical third, I'm going to leave it and observe. Because let's be honest, boys and girls, if we leave a broken instrument right in the apical 1/3, it's probably better than most people's crappy root fillings. I'm sure you'd agree. But I need a microscope to do this. I can't even begin to think about doing it without the magnification. So I need magnification, I need ultrasonics, and I need different types of especially these long ultrasonic tips. So I take a Gates Glidden, number 2, and I cut the head of the Gates Glidden down. And then I go into the canal and I form a platform over the broken instrument. And then I use a long ultrasonic tip to unwind this out of the canal. This works very well, and it can be very, very quick. So here we've got this broken instrument deep inside the canal. I'm going to go at it with my ultrasonic after creating a platform and look very closely because this happens quickly. We go in. There we go. Whoosh. Woo. Here we go. See it moving? Bang. Out it comes. And we're ready to shape and clean the canal. And then ultimately fill it. Does this technique work? Yes, it does. If the instrument is before the curvature, you can remove nearly every one. If it's at the curvature, you can still remove it. So if it's beyond the curvature, you've got very little chance to remove it. So don't go for it if there's any of you endodontists out there, because you're going to ruin your chances and you're just going to remove too much tooth structure. This is the limit of how much tooth structure I want to remove. Anything more, and I have a very weak tooth. Cliff Ruddle developed the instrument removal system using a microtube. So he exposes the head of the broken instrument, and here we have a tube with a little window, and then a wedge goes into the tube, locks the instrument into place. It's easy, isn't it, eh? Looks really easy. It's not easy, it's pretty difficult. Here's a case where I did with the microtube technique. Sometimes I can't get the broken instrument out, so I bypass it. I'm going to use ultrasonics. I'm going to use an ultrasonic chuck on this ultrasonic handpiece with an ultrasonic number 15 file. I'm going to work it into the canal with water, and the instrument is moving up and down, up and down, up and down, but it just won't come. So I decide to leave it. I'm going to bury it inside the gutta percha. I know it's there, you know it's there, but you have to tell the patient it's there. Yoshi Teruachi, you may not have heard of him. He's the king of instrument retrieval. He's developed this special kit. He can get every broken instrument out. Stephen Buchanan once asked him, I asked my good friend Dr. Teruachi how many canals he shaped with a given nickel titanium file before discarding it and bringing a new file into the procedure. He answered, I use rotary files until they break. I remove the broken segment and then I get a new file. What? I thought to myself as I looked at him like he had two heads. This is Yoshi's video. So the cone beam is going to help to identify the exact length of the instrument and its location, and more importantly, the inside curvature. So we pre-curve the ultrasonic tip that comes with the system, and we work on the inside. And you can see that the instrument is moving. Yoshi says it's dancing. He then has this little loop, bends it to 45 degrees. I went on a course with Yoshi in February, but unfortunately, due to COVID, I never had a chance to try it out. Yoshi reckons he can get every broken instrument out. Here we go. Yoshi Teruachi. So we get perforations. We have to repair them with calcium silicate cements, bioceramic, root canal repair materials. They're all variation on the same sort of chemistry. They're completely biocompatible. They're non-mutagenic. They have a great sealing ability. stimulates biological response, stimulates reparative dentin, and they have antimicrobial properties. We can place them with carriers. These are Dovgan carriers, or we can use something like the Protoidontaire PD MAP system. We also use this for apical surgery as well. So we have a perforation repair. So we're going to clean the repair and place a small little aliquot of ceramic repair material, plug it into position. Does it work? Yes, it does. And when the repair is immediate, it's far better. MTA, bioceramics, is associated with cementum formation. So I'm going to get these silver points out. I'm going to remove this core material, but I have to be very careful because I don't want to destroy the heads of the silver points. I expose the heads of the silver points delicately. And then I notice there's a pledget of cotton wool inside the pulp chamber, and it's slightly discolored. And I'm thinking to myself, when I remove this, I'm going to be in for a Pandora's box. And hey ho, there it is. Perforation. I clean up the perforation. My God, it's a big perforation. I seal that perforation with MTA. There's probably quite a bit out of the tissues into the bone. I don't know how much. But it's biocompatible, so it doesn't really care. I don't really care. A week later, it's set. And the tooth is restored with the core. And 10 years later, patient never had the restoration, but the tooth is still surviving. I don't like this. I don't like the look of it, but I call it ugly dontics, and it's worked. We can use this technique for apical closure. So we have a wide open apex, and we can push a bony matrix of hemocollagen or calcium sulfate through the end of the canal. We can clearly see with the microscope. I'm going to remove the post and the crown. Going to remove this paste material. We have a wide open apex. The patient is desperate to save this tooth, doesn't want to lose it, so we gave it a go. Place an apical plug of MTA. Here it is. Restore the tooth. This is a 10-year recall. So a large area of endodontic origin related to this central incisor, sealed with a 5-6 millimeter plug of MTA, restored coronally, backfilled with gutta percha, 6-month healing. All done in a single visit. And finally, a quick look at apical surgery. Apical surgery is now very much related to microscope usage. And there is no doubt that when we use a microscope technique for root end surgery, we can expect a significantly greater probability of success. And the evidence is pretty unequivocal on this. The influence of high power magnification has really upped the game in terms of endodontic surgery. So we have dedicated endodontic ultrasonic instruments for retrograde preparation and dedicated instruments for surgery. Microsurgical tissue elevators, curettes, and ultrasonic tips. Micropluggers, ball burnishers, and instruments to place material under the microscope. And tiny mirrors so that we can clearly see. Ultrasonic tips. Here are the ultrasonic tips from Satellec. And you can see our mirror as compared to a standard mirror. So we can make a preparation into the root end, which we ultimately seal with bioceramic sealer. A microsurgical incision done with a microsurgical scalpel blade. Retractors and elevators. Ultrasonics instead of handpieces. More ultrasonic tips. Clear view. Tiny mirrors. Control the bleeding with hemocollagen or calcium sulfate. Keep that bleeding at bay with these these non-adherent Telfer pads and do an apical retrofill with any of the bioceramic materials. Make tiny little bits of bioceramic material and easily place them into our retrograde cavities. So here's the ultrasonics. Great grip control, no bleeding. The assistant's in there helping me. This is what we're seeing under the microscope. And here's another case that's being sealed with biodentine, a bioceramic material. Biodentine is a wonderful material. It can be difficult to see on the radiograph. And there's the final outcome. You cannot see that too clearly. Here's another one sealed with MTA. And here we have a lateral perforation sealed with MTA. So I need to conclude because it's getting late. And I hope I've managed to convince you that the functional survival rates are high for both types of treatment. Endodontic treatment on a hopeless tooth is just as unethical as extracting a restorable tooth and replacing it with an implant. And since outcomes are similar with either treatment, decisions should be based on other factors such as restorability, cost, aesthetics, potential adverse outcomes, and ethical factors. So I leave you with this final comment, and we have a few questions afterwards. According to Cliff Ruddle, the natural tooth is the ultimate implant. And as I said earlier, your patients, if they break a leg, they go to emergency, A&E, they don't expect to come home with a wooden leg. Your job is to save teeth, keep the teeth for life and or for as long as possible. So, thank you very much. We have some questions, which I'm quite happy to, let me just have a look here. Hassan has asked me regarding the Wave 1 Gold, when would I decide to prepare the canal only for a yellow small? Or do we have to reach for the red primary in at least all cases? I always go with the primary. My ultimate objective is to shape every canal to a primary. I only really use the small if I can't get the primary to length. So it's a bridge file from the glider to the primary and back again to the small. Then when the small has got to length, I can go back in with the primary. Mark has asked a question. Can I have the name of the fiber post removal burrs again, please? This is the Ultradent Unicore system. So Hassan has asked the question, can we fill an open apex with biodentine, or is it better to use Angelus MTA? It doesn't matter which one of those bioceramic materials you use, Hassan. They're all basically the same. It actually becomes the question of which one you feel more comfortable using, because they are very technique sensitive. It does look like the bioceramic sealers, Endosequence putty, Endosequence root canal repair material are becoming very, very popular. So I think I'm just about finished. So if we have any more questions, I think we'll call it a night. You have my email address. It's up here. It's jw@julianweber.com, or my website is www.roottreatmentuk.com, and I'm happy to help you with any questions ultimately. Thank you for your nice words. I hope you enjoyed the lecture, And please enjoy the rest of the evening. And please, I hope everybody's slowly getting back to work, taking all the precautions necessary in these COVID difficult times. We'll have a look at these COVID-related emergency issues on Monday night. So guys and girls, thanks very much. I'm gonna finish this meeting.